this radiopacity here in the anterior left mandible in that number 22 area. You can also see this number 22 looks a little bit rotated, right? You don't have that ortho bracket there on the buccal or facial surface. Looks a little bit unusual, so that's maybe an area that we want to consider checking out a little bit more. But we'll come back to that in just a second because we have another patient coming in, this time a much younger patient. Obviously, we can see all of the developing maxillary and mandibular dentition. And one thing that might jump out to you as you start going through this pano is this little radiopacity here in the left maxillary sinus. And that's a little bit unusual because what we typically will see in the maxillary sinuses, if we see something at all, it's usually just a little bit of a soft tissue radiopacity along the floor and maybe posterior wall of the sinus there, what we would consider to be mucosal thickening. But in this case, that soft tissue area appears to extend past that posterior wall of the maxillary sinus. And that's a little concerning because we shouldn't have mucosal thickening extending out past that sinus wall. So all of a sudden, we're concerned about some kind of potential pathology in this case. And unfortunately, with 2D imaging, this is kind of all we've got to go off of, right? And so we don't have a lot of insight into what this could be. It looks a little bit dangerous for this patient. So we're going to come back again in just a minute and take a closer look because we have our last patient here coming in to our office today. Obviously, a dentulous patient, a little bit older. This patient's currently in dentures, just coming in to, I guess, fix the dentures that they currently have, get a new set, maybe look at some implants to support the dentures that they have. But again, pretty typical, pretty straightforward panoramic radiograph. Are there any concerns or issues that you might see? Yeah, right off the bat, probably not, right? It is a little bit of a funny pano. We typically get this with more dentulous patients where it's hard to keep that vertical dimension. You have the patient leaning forward a little bit. You can see the spine coming into this view here. But otherwise, nothing obvious that might jump out at us if we're going over this scan pretty quickly. So the question is, what are we missing? Well, with 2D imaging, we don't get a lot of information. You can see the general structures, especially on our panos. You can see the general structures, but there's a lot of times missing information. And that's a big concern because our diagnostic imaging, that's how we get information in order to diagnose and treat our patients. And if we don't have all the information that we need at hand, makes our treatment poor. And that's not something that we want, right? We want the best treatment that we can get for our patients. We want good, predictable results every time. And especially when we get into things like pathology, which is what we're talking about today, it's very, very important to have all the information that we can possibly get. So let's go back and look at some of these cases, but add in more information that we get from taking a CBCT scan. So going back to this first patient, we already noted this radiopacity, and we'll take a closer look with our 3D imaging. So sure enough, even showing up on the 2D imaging here, we have this radiopaque area. And as we said, that tooth number 22 is not positioned entirely correctly. What was happening in this case was that the orthodontist was trying to move this 22 into this into its proper position. That number 22 got a little bit pushed outside of the mandibular arch. And the question is, what is this radiopacity here that had caused that? So this radiopacity, we'll talk a little bit more about this later, but this is what we call a dense bone island or idiopathic osteosclerosis. It's essentially an area of dense cortical bone where trabecular bone should be. And as you can imagine, the increased density of the bone in this area makes moving a tooth through that bone very, very difficult, to the point where this tooth was pushed out buccally instead of into the alveolar arch. But thankfully, these are normal variations. Dense bone islands are totally benign, completely normal. In this case, it just had a very unusual consequence to being here in this 22 area. Unfortunately, though, for this patient, that's not all that was present here in this panel. And if we take a look up here in this left posterior maxilla, there's a very, very faint line that's running from the floor of the sinus to this posterior wall of the sinus. Very subtle. You can see it's a little bit more radiopaque than the rest of the sinus, but something's definitely there, and it's a little difficult to pick up on. Moving to our CBCT scan, we have a axial view of the maxilla here. We can see our right maxillary sinus, our left maxillary sinus, and as we had noted in that panoramic radiograph, we do have something here along that posterior wall of the maxillary sinus. And this is not normal. If we compare it from the left side versus the right side, we can see that normal posterior wall of the maxillary sinus. And you can see how that sinus wall has been thinned and expanded both posteriorly and anteriorly into the space of the sinus. If we look at that from the sagittal view, you can see that border of this lesion here, and we actually can see that there's almost a granular appearance, some radiopacity within this lesion. So very unusual, very interesting.
Sorry about that, everybody. We're just gonna work out some of these technical difficulties. Doctor, let me know when you're good.
Can you hear me?
I can hear you now.
Okay, good. Sorry.
Wonderful. Let
I
me
think
have
my
your word.
headphones just cut out randomly, but we're good.
That's okay. All right, we're good to go. Thank you,
Yep,
doctor.
no problem. Okay, so this lesion here, definitely an unexpected finding, especially when the patient was coming in just for general dental purposes, also to address that dense bone island in the front, but very, very important to catch these kinds of lesions because for this patient, they're probably not going to notice that anything is occurring way, way back in the posterior maxilla. Probably no clinical signs or symptoms at this point, and so your radiographs are really all that you have to catch this lesion. So when we're talking about pathology, again, it's very important to have all the information that we can possibly have because we don't want to miss anything. This next patient, we were talking about the left maxilla. We had noted this little radiopacity here in the left maxilla. And if we move into our CBCT scan, we can see much more of what's going on in the sinus, and that allows our diagnosis to be much more accurate. We'll start off with the sagittal view over here on the right side of the screen. We do have that soft tissue density radiopacity here along the floor of the maxillary sinus, but what we don't see is any changes to the posterior wall of the sinus itself. If we back up to this pano, we were certain that this had extended past that posterior wall of the maxillary sinus. And so pulling up the CBCT scan again, we can see that there's no changes here, no changes here. Everything looks absolutely normal, which is great for this patient. Again, they're very young, they're developing all their dentition here. And so what we decided was that what we were seeing in the panel was, yes, this mucosal thickening here along the floor of the sinus, and then probably something to do with the turbinates here. They look a little bit enlarged, maybe some congestion. So probably a combination of some sinus findings as well as probably the turbinates that we're seeing superimposed over this area. Thankfully, again, no pathology here for the patient, but without that additional information, we could start making all kinds of worrisome claims to this patient, right? Like, if we're just taking this 2D image, all of a sudden we're getting them out to ENT, to oral surgery, patients freaking out. The parents are freaking out. Obviously, we want to exclude pathology, but it's much easier to do so when we have the additional information. And then for this last patient, we didn't notice anything in particular here, but that's kind of concerning because there definitely is something that's present. Here in the anterior maxilla, we have a well-defined radiolucency. It's hard to tell if this is entirely associated with the nasopalatal duct. Looks like it might be continuous with it, so it might be a nasopalatal duct cyst. It might be a residual cyst from previous infection and maybe number 8 in the area. Really, we don't have any way to tell one way or the other than to identify it and biopsy it. For this patient, it's very, very important that we see this. The reason why is because you're not taking any periapicals on this patient because they don't have any teeth. We already took a pano and we obviously did not catch this on the pano itself. And so having, again, the additional information from CBCT scan, very, very critical to your daily practice, especially when we're looking at pathology. So what have we missed? We are missing quite a lot when we're just relying on our 2D imaging, which is kind of concerning because that's our quote unquote standard of care at this point in dentistry. And I want to spend today talking about pathology and how we can utilize that to, or how we can utilize CBCTs to review for pathology and what exactly we are looking for. Okay, so pathology and disease. Our 2D imaging, we hopefully should be very familiar with what pathology looks like on our 2D imaging. Here in the right posterior mandible, this is hopefully very clear to all of you that pathology is present. This is an ameloblastoma. It doesn't really matter what it is, but it's really important for you to just identify that pathology is present. This is what we would call a multilocular radiolucency. We can see displacement at number 32. We can see resorption of the roots of teeth numbers 29 to 31, expansion of the buccal cortex, thinning of the cortices as well. All very classic signs of pathology. But how do these features translate into our 3D imaging? Well, I do want to back up just a second because in order to understand what pathology looks like, we need to understand what normal looks like on our 3D imaging. So this is a axial view of the mandible on CBCT, and then this is a coronal view of that same mandible. And the features that we're really looking for when we're checking out pathology, we're not really paying attention to the teeth. We're looking at the cortices and we're looking at the trabecular bone. And what we want to see on our 3D imaging is this nice, thick cortex running along the buccal and the lingual surfaces, obviously, as well as the inferior cortex and the alveolar crest where we can see it. All of these cortices need to be regular and intact with no significant changes or sudden changes into the thickness. So what I mean is that if we were to measure this and this was, say, 2 millimeters thick, we wouldn't want to move just a little bit more distal and all of a sudden it's just 1 millimeter thick, right? We don't want any cuts or scoops out of these cortices because that would potentially indicate that there's pathology present. And then obviously, same goes for the trabecular bone. We want there to be relatively nice and uniform trabeculation throughout the mandible. Obviously, there's going to be some amount of changes between the anterior and the posterior mandible, but we want to see more gradual changes to make sure that we're not dealing with pathology. Now, anytime that we do see changes to these, either the cortex or the trabecular bone, that would indicate that we are dealing with some kind of pathology or some kind of disease process. So if we were to jump back to our 2D imaging, we have a multilocular radiolucency here in the left posterior mandible. You can see that there's thinning here along the inferior border, not a lot of displacement of these teeth, no root resorption. But what would these features look like on our 3D imaging? We're going to start out looking at a axial view of the mandible here. Here you can see the obvious affected side and all the thinning and expansion of the cortices, but what I want to point out is the changes to the bone that we notice. So over here on the right mandible, you can see nice thick cortices of the mandible, and we're actually going to bring this down a little bit. So you can see the thickness of the buccal cortex, thickness of the lingual cortex, and then when you compare.
Okay, everyone. Sorry about this. All right, everyone. Let me just see if I can get the doctor back in here. Just give us a moment, please. Sorry about this. Technical difficulties. We will have the doctor join as soon as possible. Give us a moment, please. Thank you. All right.
Okay. I don't know what's going on tonight. You're on mute, by the way. I don't know what's going on tonight, but man, it does not want me to present this lecture.
Very,
Holy cow.
it's the Halloween theme, right? Very spooky.
I guess so.
Well, welcome back.
Man,
Glad to have you back. Did you want to pick
yeah.
up again?
Yep, we'll try again.
Have at it. Take two. Take three.
Yep. Okay. Good. Okay.
Good.
Awesome. All right. So, before I was kicked off Zoom, we were talking about the thickness of the cortices here. So the lingual cortex, the buccal cortex, very thin compared to the right side. And that's the kind of changes that I'm looking for as I'm reviewing this scan. I'm going through, reviewing the maxilla, going through, looking at the mandible, checking for these changes to the cortices. Obviously, I want to see that there's no loss of trabecular bone as well, but it's really the cortices that tip me off as to whether or not pathology is present. If we move to the coronal view, we have more of the same, where we have thinning of the lingual cortex. We can also appreciate a little bit more of that expansion as well. Very subtle, very mild expansion for how large this lesion is, but it's still there. But again, as I go through scans, I'm checking the cortices and making sure that they're nice and regular and intact, no thinning, no expansion. And that's really the first clue that we're dealing with pathology. So in this case, this is what we call a simple bone cyst. It's a little bit more common in younger patients, but thankfully very, very benign for this patient. Okay, here is our first quiz of the night. So I want you to apply what we've just been talking about to review this single screenshot of an anterior maxilla. So we want to be looking at the cortices, want to look for any significant changes. I tried to pick a little bit more subtle case so that you don't have an obvious radiolucency or radiopacity just jump out to you. But if we follow along the cortices, we want to look for any changes here, any obvious changes. And now obviously it's a little bit difficult when we're just looking at a still image, but you can definitely appreciate this focal disruption within this cortex, just lingual to tooth number 10. And if we were to pull that up on, say, a sagittal view, you could see a lot more changes to the trabecular bone in this area. This ended up being cemento-osseous dysplasia, another very benign entity. But again, you want to check for those changes in the cortex. The trabeculation here definitely a little bit changed, but not very obvious compared to what we're seeing with the cortex. Now, there's other conditions that are going to change the cortex. Obviously, the thing that we're most familiar with is apical periodontitis, or just plain old good infection here. So whenever we have infection associated with the roots of teeth, we can see some perforation of the cortices. This is where you get those little fistulas or the sinus tracts. You have the little bump on the gums, and this is what those look like radiographically. You have that that infection originating from the root apex, and as that continues to grow, it can erode away that adjacent buccal cortex. You can see this patient has a lot of infection present here, so you have quite a few areas where this cortex has been lost. And the big important thing is to always trace that back to a tooth, typically the root apex of a tooth. And if you can trace that back to a tooth, you can vitality test that tooth. If it's non-vital or if it's symptomatic, you're pretty much guaranteed to be dealing with some kind of infection. Sometimes it does get tricky when the tooth has been root canal treated and you can't do vitality testing and the patient's asymptomatic, but it looks like infection. Sometimes that's a good time to reach out to a oral radiologist who can hopefully help you make a decision whether or not you're dealing with persistent infection or pathology. So here's quiz number 2 for the night. Again, a little bit practice for reviewing scans for pathology. So we're going through and we're looking at the cortices of the of the maxilla. So literally, as I'm going through scans, I'm just tracing those cortices. I'm looking along the front, come along here, and then, oh, hey, there's a little perforation of the cortex. Doesn't really make sense that there should be some kind of cortical perforation in this area, so I'm going to take a little bit of a closer look here. So here again, an axial view in that number 13, 14 area, looking at the sagittal view, very large area of bone loss extending from the alveolar crest down to the area of the root apices. Doesn't make sense, right? This patient, if we were to look a little bit closer throughout the rest of the mouth, they don't have uh, periodontal disease elsewhere, right? It would be very odd to have such a focal spot of bone loss here that's present. And so this was recommended to be biopsied, and biopsy ended up coming back as squamous cell carcinoma. So again, very important for this patient that we're catching these kinds of things. Other times that we'll see changes to the cortices are when we have younger patients with their developing dentition. So dentition that's developing obviously is going to have to emerge through the cortices of the mandible and maxilla. So you're going to get many areas where that cortex is thin or perforated as that tooth erupts. Now, the tricky part is trying to decide whether or not these changes to the cortices are associated with pathology or associated with the teeth. Whenever we're seeing younger patients, you always have to, again, trace it back to the dentition. So we have these areas here in the number 22, 27 area where you have lots of thinning and perforation of those cortices. We have to make sure that those areas make sense, right? If we have thinning and we have perforation of the cortices where we don't have erupting teeth, now we have to start considering pathology. So for this case, we have lots of areas of developing and erupting teeth, so lots of thinned and perforated cortices. All of that makes sense though, right? You have these developing teeth, they're supposed to be there, these changes are normal. But what isn't normal is here in this left posterior mandible. This, if we look a little bit closer, is not associated with a developing or erupting tooth. We just have thinning of that cortex, maybe some mild expansion here. But if we were to look back at this tooth here on the pano, there's nothing erupting in that area, so there's no reason why there should be changes to that cortex. So this was pathology. And on the previous slide, we noted this as another simple bone cyst, but very early in this stage for this pathology. One of the things that I'll also point out is if you're just looking at the trabecular bone, it's not really going to help in this case. This patient, for whatever reason, just anatomical variation, they have a lot of large marrow spaces. So these large radiolucent area where just Marrow is present and very little trabecular bone itself. If you're just looking at these trabecular spaces, you're going to miss this radiolucency here. It's really the thinning of this cortex that's the only indication that pathology is present. And then if you just have 2D imaging, you're not going to pick up on this lesion, right? It's very, very subtle, very early at this stage. You need 3D imaging to pick everything up. So let's go ahead and talk about some more common findings in the mandible and maxilla specifically. There's lots of different cysts, neoplasm tumors that might arise in the mandible and maxilla. It's not really important for you as a dentist to know exactly what the name is of whatever radiolucency you're dealing with. What's important for you is to find it. So we'll just go through these pretty quickly. We're just going to cover the more common ones just to give you a couple different examples of what you might see, how those pathologies affect the surrounding trabecular and cortical bone. But again, you don't need to know the names of these because as long as you can identify them, you can get these referred out to an oral surgeon or oral radiologist who can help you identify what exactly the patient's dealing with. So the most common cyst, other than like a radicular cyst, but most common what we consider pathology is a dentigerous cyst. So these are associated with impacted teeth, typically third molars. We also see these sometimes in canines. I just had a case the other day that was associated with a supernumerary tooth, and they typically present as pericoronal radiolucencies. You can see this radiolucency is attached at the CEJ, and if we were to move through in 3D space, you would see that it's pretty much all attached around that crown, which is why we call this pericoronal. Pretty common. We can see them in the mandible. We can see them in the maxilla. A lot of times in the maxilla, you'll see these teeth superiorly displaced into the sinus. So if you see a tooth, especially on your 2D imaging, that's being displaced superiorly, it looks like it's just kind of floating in the sinus. Make sure you get more information, right? Make sure you get some kind of 3D image to make sure that you're not dealing with some kind of dentigerous cyst. Odontogenic keratocyst is another very common pathology within the mandible and maxilla, typically more found in the posterior region of the mandible, but really we see them anywhere and everywhere. Pathology never reads the textbook, which would make it so much easier, but these can really be found throughout the mandible, throughout the maxilla, anterior, posterior. In cases of odontogenic keratocyst, typically these lesions don't cause as much expansion as some of our other lesions. So you'll typically see them with a elongated appearance where maybe you'll see them throughout a quarter or half of the mandible before you really get much expansion of the mandible itself. Not really something that you need to know, but just some fun fact about odontogenic keratocysts. Ameloblastoma, these I would consider a little bit more aggressive than odontogenic keratocysts. I guess it just depends on the specific type of ameloblastoma. There's solid, there's unicystic, and each of those have a little bit different characteristics to each other. But again, the most important thing is that you can identify them. And we can see the very classic multilocular appearance of this ameloblastoma. You can see the buccal expansion, the thinning of the cortex in this area. Very, very common to see all these features in ameloblastoma. Central giant cell granuloma, again, more thinning, more expansion. Here we get some resorption of the apices of the involved teeth. We can also see some wispy septations throughout the lesion as well. Changes to the cortices and trabecular bone really are what we're looking for in these cases. And then another example of a simple bone cyst. A little bit of thinning of the cortex down here, some changes to the trabecular bone as it scallops in between the root apices, very classic appearance of a simple bone cyst uh, that are typically found in younger individuals as we have here. Okay, test number 3 for the night. We have another lesion somewhere here in the maxilla. So as we trace out our cortices, as we come around into this number 9 region here, the anterior maxilla, we can see quite a few changes along that buccal cortex as well as that palatal cortex too. And then throughout this area, we have what looks like a very ill-defined radiolucency, right? We don't have a nice defined cortex like we were seeing in our previous benign pathology. And if we move over to our sagittal view, we can see more of that irregular and kind of insidious appearance of this lesion. This of course is a malignancy. Whether this is a squamous cell carcinoma, osteosarcoma, again, doesn't really matter. What matters is that you find it. This, again, is a little bit more subtle just because we don't have very well-defined margins. We don't have obvious expansion. It's really just those changes to the cortices, the changes to the trabeculation. You do have to be careful though, because malignancies, they can be very subtle in their change of trabecular bone. And so you might have just a very faint, fragile appearance from normal trabeculation to the malignancy itself. So those changes to the cortex, that's really what you got to be on the look for when you're reviewing these scans. Another example of malignancy here where you can see that destructive infiltrative appearance. We're literally losing half of the nasal cavity here due to this lesion. You can see all of the structures here within the sinus and the nasal cavity are just completely obliterated. Very, very characteristic of a malignancy. Okay, moving on to other entities in the mandible and maxilla, we're going to move away from our radiolucencies and talk more about a few radiopacities that you might run into. Here we have tooth number 30, and you can see it's been root canal treated, but this root canal has failed. You can see a lot of bone loss in the area, but the bone loss isn't really what we want to talk about because we've seen apical periodontitis a million times. What I did want to talk about is all the sclerotic trabecular bones surrounding this area. So if you look at this normal trabeculation here, distal to number 31, as you move closer to this area of infection, you can see that trabecular bone has become very, very sclerotic. This is what we call condensing osteitis. So this is a response to chronic inflammation in the mandible or maxilla. Essentially what happens is your body is reacting to that chronic inflammation, that chronic infection, and it's essentially trying to wall off that infection by laying down additional bone. And that additional bone presents as a more sclerotic appearance on our radiographs, and that's why you get this radiopaque area surrounding this area of infection. Condensing osteitis, since it's a response to that inflammation or infection, you're always going to have some kind of symptomatic or non-vital tooth in that area. You're going to have a apical periodontitis, right? Here's another couple views of that same area. If we're looking at the right mandible here, we have nice radiolucent trabecular bone, but as we make our way over to that area of infection, you can see how sclerotic that trabecular bone becomes. Same thing over here on our coronal view, that sclerotic bone is essentially taking up the whole entire mandible at this point. We can still see this present even after we extract the teeth sometimes. It takes some time for that trabecular bone to return to normal. And so in this case, if we're comparing the right side, we have normal trabeculation. The left side, we have very, very sclerotic bone. This radiolucent area here in the middle of this mandible, that's our mandibular canal, right? It's really the only thing that's radiolucent in this whole entire area. Axial view, you can see that gradual change into this sclerotic bone. Again, condensing osteitis, it's that reaction to infection. Another case where we have quite a bit of infection throughout the mandible. And what's happened is that the entire anterior portion of the mandible has just become totally sclerotic, to the point where you can see all these little nutrient canals, all these vascular channels, neurovascular channels going to the anterior mandible here. Just kind of a fun appearance with how sclerotic this bone is, with the canals running through the anterior mandible. Now the question is, what do you do with it, right? You have all this sclerotic bone. Uh, it appears very unusual to what we're used to. So does it need a biopsy? Does it need to be treated? And generally the answer is no. So again, it's a response to the inflammation associated with the tooth. And so if we remove that source of infection, this bone will gradually turn back to normal bone. It'll remodel and slowly become more radiolucent, more typical of the normal density of bone. Sometimes, though, literature says about 15% of the time that sclerotic appearance will continue and persist, and it's nothing that needs to be treated or biopsied. We just consider it to be a scar, and it looks funny, but it's totally fine. Another radiopacity that you might come across, and actually I'm almost willing to guarantee that you'll come across this, is lesions like this or radiopacities like this, where it's a very well-defined radiopacity. It's very homogeneous in appearance, right? You have this one kind of color or shade of white that's throughout the whole entire lesion. If you're looking at the tooth, this tooth is totally normal. It's completely vital. You can see the PDL space. Everything is regular and intact. Everything looks normal except for this kind of weird radiopacity hanging around. This is what we call a dense bone island. A dense bone island we talked about at the beginning when we were talking about one of our interesting cases. Dense bone island is a normal anatomical variation where cortical bone has formed in the area of trabecular bone. Now, we know this is not pathology because of a couple different features. One, and probably the most important feature, is that there's no thinning or changes to the adjacent cortex. Where this radiopacity comes in and meets this lingual cortex and this buccal cortex, you can see that it kind of just blends in seamlessly, right? There's no thinning, there's no expansion, there's no changes whatsoever. And so that's how we know this is just normal cortical bone, right? Because it's blending in with the adjacent cortical bone. So this is normal. This is totally fine. Patient's not going to have any symptoms. They're not going to have any issues, but we see this quite a lot. I think literature states that it's about 1 in every 20 patients. I would probably say we see that a little bit more often in my private practice. Maybe it's just because people are sending us these because they're concerned about them, but we see them quite a lot. And while traditionally they have a more circular appearance, they can really be completely amorphous. So they don't have to have a nice round shape. They can be kind of sporadic, but we're always looking for those defining features of where they meet the cortices, they kind of just blend into that adjacent cortex. They're generally very homogeneous in appearance. They aren't granular. They're very radiopaque and just that one shade of white. Really no issues here with these patients. Again, they are normal anatomical variations, so we're not biopsying, we're not treating. Patients shouldn't have any symptoms. It does become a problem sometimes when we're trying to do ortho treatment, like we saw in the earlier patient. It's very dense bone, so it makes moving teeth much more difficult through those areas. It can also be a little bit complicated with implant planning. If you have these massive areas of cortical bone that you're trying to put an implant into, you got to imagine that you're going to run into a lot more resistance. You're going to end up generating a lot more heat. And so you want to be aware of these before you get into the surgery itself so that you can have new drill bits, you can have more water and irrigation to reduce that heat generation. But in general, again, normal bone, it's just a little bit more dense than what you're normally used to. Our next lesion here is a favorite of oral pathologists and oral radiologists. Hopefully shouldn't be a surprise to you, but we have these radiolucencies here at the root apices of 24 and 25. You can see that here on our periapical as well. What I hope you can also appreciate is the nice continuous PDL space around these roots. There's nothing wrong with these teeth, so why do we have these radiolucencies? And if we look a little bit closer on our CBCT scan, you can even see some radiopaqueness to these lesions as well. These are areas of submental osseous dysplasia. These are pretty classic lesions that we talked about quite a bit in dental school and residency, but they have a very unique demographic to them. For whatever reason, probably genetics, I don't know. But these are classically seen in middle-aged Black or Asian females. Typically, whenever I get a case sent to my private oral radiology practice, if the doctor has put in the notes like, hey, there's some kind of radiopaque radiolucent lesion, patient's a Black 35-year-old female, I almost don't even have to open up the scan because I know it's going to be cemental osseous dysplasia. Obviously, I still open up and look at the scan, but 99.999% of times it's going to be cemental osseous dysplasia just because it has such a predilection for these patients. Now, cemental osseous dysplasia, it's typically fairly straightforward to diagnose, but in its very early stages, it's a little bit tricky. The reason why is because cemental osseous dysplasia starts off as completely radiolucent, and it's typically found at the root apices. And that's a little complicated because a radiolucency at the root apex of a tooth looks a whole lot like apical periodontitis, right? It looks like a tooth infection. But thankfully, if we were to go ahead and test these teeth, they're all going to test vital. So that's the big important thing to note when you're dealing with these early lesions of cemental osseous dysplasia. You got to test these teeth. Now, ideally, we would be always doing vitality testing on any tooth before doing a root canal, but sometimes that's not the case. We run into quite a few cases where a doctor has done a root canal on a tooth that has what looks like just a radiolucency at its root apex, but it's actually cemental osseous dysplasia. And sometimes they go a couple steps further and not just one, not two, but three root canals and an implant into not what's infection, but cemental osseous dysplasia. So not entirely sure how all this happened in this case, but unfortunately for this patient, they did not need any of this treatment here. Now, as this lesion of cemental osseous dysplasia continues to progress and mature, we end up with our more classic appearance of cemental osseous dysplasia, which is where we have a radiopaque center surrounded by a more radiolucent border. We can see that an example of that here, just distal to tooth number 30 or 31. And we can also see a little lesion here next to tooth number 29, which is very small there near the root apex. And then as these patients with cemental osseous dysplasia continue to age, we end up with very mature lesions of cemental osseous dysplasia where they're almost completely radiopaque. You can also see how they adhere to the adjacent roots of the involved teeth. This typically isn't a problem until you want to go in and extract one of these teeth, and all of a sudden they're all kind of attached. And so it does kind of create a mess sometimes. So while cemental osseous dysplasia typically isn't something that needs to be treated, it can pose some complications with certain conditions. Here's a pretty typical presentation of cemental osseous dysplasia. You have this mixed density appearance where you have these central radiopasties and the radiolucent borders around those radiopasties. Very often you'll see thinning and very minor expansion with these lesions. One of the nice things about cemental osseous dysplasia is that they are often multifocal. So if you have a lesion in the anterior mandible, oftentimes you'll see it in the posterior mandible or anterior maxilla, posterior maxilla, whatever. It makes it a lot easier to diagnose cemental osseous dysplasia when you have these multiple lesions because very rarely is pathology multifocal. So when you have a patient with very characteristic appearance of cemental osseous dysplasia, you have multiple lesions throughout the mandible and maxilla, and they fall into that demographic of middle-aged Black or Asian female. It's a slam dunk and super easy cases as an oral radiologist to read out, but you just have to know what you're looking for and how to diagnose this. So for cemental osseous dysplasia, thankfully, it's a very, very benign condition. These lesions form and they're asymptomatic. They don't resorb teeth. They don't displace teeth. They just kind of pop up and stick around, and it's great. So the only thing that we really do for them is we just monitor them. Sometimes cemental osseous dysplasia can form simple bone cysts or become secondarily infected and be a source of osteomyelitis. So we do recommend monitoring these every year or two just to monitor for any significant changes. We often anticipate there being slight changes like slight growth or continued uh, radiopacities developing within these lesions, maybe more lesions forming, but in general, they get to a certain stage and kind of just stop growing. So uh, nothing really exciting as far as cemental osseous dysplasia goes, but if you have a question about what you're looking at, is this cemental osseous dysplasia, you can always reach out to an oral radiologist for help. Okay, with the last 12 minutes or so that we have, I want to talk about some soft tissue radiopacities. So here within the soft tissues of the neck, we have this radiopacity that is extending from what looked like the base of the skull, right? We can back up here, that area, the TMJ, extending down into the area of the neck, just right here by the hyoid bone. So the question is, what is this thing, right? Now, it might look a little bit more familiar if we put it on our 2D imaging. And sure enough, that's our stylohyoid ligament that has become calcified. Now, calcifications of the stylohyoid ligament, these are normal physiological calcifications. Don't know why it happens, but it happens in many, many, many patients. So there's a lot of different presentations of stylohyoid ligament calcifications. You can have continuous calcifications, you have segmented or interrupted calcifications. It can be a lot, it can be a little, it can be very minor, it can be very significant. But again, these are generally normal physiological calcifications, and they really generally don't cause any issues for the patient. Here on our axial view, these calcifications appear as very well-defined circular radiopacities, and they typically flank the airway on either side. And as you scroll through the scans, you'll see them appear, you'll see them disappear as those calcifications come into view and disappear. Not a big deal, but it's primarily something that we point out just so that we can recognize normal anatomy. Because there's other things, other entities in these areas that we don't want to get confused with. So you need to know what our normal anatomy looks like, right? So again, no treatment because they're normal physiological calcifications. There are some scenarios where the patient might have pain on swallowing or turning their head. That might be a indication for Eagle syndrome, but very, very rare compared to the amount of calcifications of the stylohyoid ligament that we see. So here's an image of a patient with a stylohyoid ligament that you can see extending down to the angle of the mandible, but there's some other calcifications just a little bit further down. So what we have is the thyroid and the triticious cartilage calcifications. So we have our hyoid bone here, and then just right underneath, we have the triticious cartilage and the thyroid cartilage. And these are other normal physiological calcifications that occur. These typically occur after adolescence. So patient hits probably their 20s or so, and you start to see calcifications of these cartilages. Again, totally normal, but we need to be able to identify what's normal. We actually see these somewhat frequently on our panoramic radiographs. Here's a particularly prominent thyroid and triticious cartilage calcification on a panoramic. This isn't normally how we see them. Rather, this next image, there we go. This is more so what we see, where we see just that little horn of the thyroid coming into view. It's always right at that posterior portion of the thyroid, or sorry, the hyoid. But again, normal physiological calcification. On our CBCT scans, it's very important to know this anatomy because there's some entities that we'll talk about in just a second that might pop up here. But the primary thing that you want to know is the relationship between the hyoid and the thyroid. So if we were to take some axial slices of the neck here, so here we're at the level of the hyoid, you can see a little bit of the anterior mandible here in this slice as well. If you go directly inferior to the hyoid bone, so literally just scroll down, you're going to hit the thyroid. So the hyoid bone, it comes around this airway here, scroll down, you hit the thyroid. And if you're taking any scan that captures below the thyroid or below the hyoid bone, you're probably going to have some portion of the thyroid. It might just be the tiniest portion of these horns that are sticking up there. That's most typically what we'll see on smaller scans, but in the larger scan, you'll often see quite a bit of this thyroid cartilage. So this is typically what you'll see. You'll see a little bit of the hyoid bone, and then you'll see just these little portions of the thyroid popping up just right there. And you can also see a little bit of the triticious cartilage. There's these very circular radiopacities, very well defined in this same region of the thyroid. So why do we bother pointing these out if they're totally normal? Like I said, there's some entities that are going to appear in this region, and we have to be very careful because they're very important to identify. So if we look at this bilaterally, we see some radiopacities here. They're not very well defined, they're not very smooth. They're very irregular, they're interrupted, and they don't quite look like a nice normal anatomy. One of the other things that you'll notice is they're much further lateral to the airway. And if we scroll down a little bit further, you'll see actually this is our hyoid bone. And what we know about the thyroid cartilage is that our thyroid cartilage has to be inferior to that hyoid bone. But these radiopacities extend fairly far superiorly to that hyoid bone. So we know it can't be thyroid. We know it can't be triticious. There's no other normal anatomy in this area. This has to be something else. And that something else is carotid artery calcifications. So carotid artery calcifications, these are radiographic evidence of carotid plaques. So carotid plaques will form in this area of the carotid. The bifurcation of the carotid occurs in this area. There's turbulent blood flow that predisposes this area to form plaques. Those plaques over time can calcify, and those calcifications are what we see on our imaging. And these carotid plaques, they're generally much more irregular than any of the surrounding anatomy. And when we compare them to our hyoid bone or our thyroid cartilage, they're much more lateral within the neck. So here we have a little bit of our hyoid bone. We have just a touch of our thyroid coming into play, just immediately around that airway, right? And just a little bit more lateral and posterior to this airway, we have some irregular calcifications. Those are carotid artery calcifications. They don't have to be very big either. In the early stages of calcifications, you can have just little pinpoint calcifications. So here's our thyroid cartilage, more posterior and lateral. You have this little tiny calcification. That's a carotid artery calcification. Couple other examples here. More irregular, interrupted calcifications. You have your hyoid bone just right here in this area. Again, this can't be thyroid cartilage calcifications because these are more superior. They're also more lateral and posterior to that airway. Question becomes, what do we do with this? Well, it's never a bad idea to refer. If you don't know what to do, refer it out to the patient's physician and they'll take care of it. But sometimes we like to be a little bit nuanced with our approach. So typically what I recommend is that your patients are going to fall into two separate categories. The first category is going to be a patient that is regularly seeing their doctor. They're aware that they have high blood pressure or high cholesterol, some kind of associated condition related to carotid artery calcifications, and they are on medication to control that condition. It's well controlled. They don't have high cholesterol or high blood pressure. So if they're continuously working with their doctor to address this condition, they probably don't need an immediate referral out to their doctor, right? Their doctor knows what's going on. And so this is something that you still want to make the patient aware of, but you can say, hey, on your next appointment with your doctor, just bring up the fact that your dentist saw some carotid artery calcifications just so that they're aware, right? Again, their doctor's already managing their conditions, so it shouldn't be much of a surprise, but we do want to make sure that we make the patient aware of this condition. Now, on the other hand, we have the other portion of our patients who they haven't seen their doctor in years. They might not even know who their doctor is. You sit them down in the chair, you throw on a blood pressure cuff, and their blood pressure's through the roof. They have uncontrolled diabetes, uncontrolled high blood pressure, high cholesterol. There's a number of conditions that are associated with carotid artery calcifications, but essentially they are a unhealthy patient. And with those patients, that's where I'm asking the patient, hey, you need to make an appointment today with your primary care physician. You need to get all of this under control. Those are the ones that are a little bit, not necessarily urgent, but a little bit more encouraging to go get this addressed or taken care of, because these are a sign of uh, poor cardiovascular health. These can lead to ischemic events, strokes, heart attacks. And so these are the things that we need to make sure the patient's getting addressed. So if I have a healthy patient, I'm still alerting them to the fact that they have carotid artery calcifications, but for other patients, um, yes, those that are uncontrolled diabetes, uncontrolled blood pressure, we need to get them to see their doctors. So with the last 30 seconds that I have, we're going to talk about the last radiopacity in the soft tissues. So we have some sporadic and multiple radiopacities here, just flanking the airway on either side. And with our radiopacities in the soft tissues, knowing your anatomy and where you're at in your anatomy is very important, because if we know where we're at, we can very easily make this diagnosis. So if we look at this scan, we're at the level of the ramus in the back of the mouth next to the airway. That puts us right in the location of the palatine tonsils. These are going to be tonsillous. This is a very typical appearance for tonsillus, where you have these multiple radiopacities. It's not a surprise to see these. These are very, very common, something that you'll see very often on CBCT images. These are just benign calcifications that typically form within the palatine tonsils, but we do occasionally see them in the lingual tonsils and the adenoids as well. This is something that we see quite often on panoramics too, but really not much of a concern. So if they're asymptomatic, you don't really need any kind of treatment, but if they're bothering the patient with some irritation, halitosis, dysphagia, they can be removed either by the patient or surgically if they're really bad. But otherwise, that is unfortunately all the time that we have today. I always plan way more than I think I'm going to be able to address. But if you have any questions, now is a great time to unmute yourself or to go into chat and ask some questions. But I'll leave this image up so you can scan that and go ahead and get your CE credit. But otherwise, we'll start checking out the chat and we'll go from there.
Okay. Now, doctor, I did see one question here, which I like. If we need to follow up on a finding, how long after do we wait to take another CBCT scan?
Yeah, so typically follow-up CBCT scans are going to be anywhere from 6 to 12 months, just depending on what we're concerned about. If it's something that's potentially very benign, we'll push it more towards 12 months. If it's something that might be a little bit more concerning, like some kind of aggressive lesion or recurrency, something like that, we'll look more towards 6 months. But it's when we're doing follow-up imaging, it's always really important to have good quality scans because there's nothing worse than starting out with a crappy scan, getting another crappy scan 6 months later, and you can't tell anything anymore. So you always want to start off with a good CBCT machine, make sure you have good imaging, and we're going to talk more about image quality and what goes into that into our next meeting. So if that's something that you're interested in, please make sure to register for the next event. There should be some information up on the Ray America website, which you can find there. But yeah, we'll be talking about image quality, artifacts, that kind of stuff next time.
Wonderful segue there, doctor.
We have another question here in the chat. Please discuss cracked teeth on CBCT. So root fractures on CBCT. They they're a little bit rare to see on CBCT. So there's instances where you're going to be able to see a root fracture on a tooth on a CBCT scan, but typically in that case, those are the kind of teeth where you can wiggle one of the cusps of that tooth and like the whole entire cusp and half of the root is moving. So generally, though, on a CBCT scan, you see radiographic evidence of a root fracture. So very focal, isolated patterns of bone loss along the root structure or along the root surfaces, but you won't actually see a frank radiolucent line going through that root. So unfortunately, it's just a limitation of resolution. The fractures are just so incredibly small that even with the really great resolution that we have on CBCT, you're still not going to be able to catch those, unfortunately. But you still see the evidence of root fractures. So again, those isolated, typically vertical, like very narrow pockets of bone loss along the root surfaces. Any other questions?
I see that we are clear of questions for now, doctor, but as sure as water is wet, once we log off, there will be a question. And please, if that's the case, feel free to submit your questions. Ray America Marketing .com. Also, if you wanted to visit again our website, rayamericainc.com. And then thank you, doctor.
Thank you so
Classic.
much.
All right, everyone. Thank you so very much for taking the time to join us today. Ray America with Dr. Barrett Andreasen, CBCT findings, common findings, and pathology. Hope to see you guys at the next one, and hope you enjoyed the content. Have a great evening, everyone.
Take care.
Thank you, Doc.